So yeah, like I said, our next trio is here to speak on embedded research programs for operations research at VCH, sorry. And instead of Andy Day, we have Jessica. So I'll invite the three of them there to come up and give their talk.
Hello, hello. Thank you all for being here. So we'll do some quick introductions, and then I'll start off first, and then Krisztina will come second, and Jessica after that. I'm Saad Ahmed. I'm a family physician and the medical director of homelessness and supported housing for Vancouver Coastal Health, and I'm also the co-lead of our embedded research program here at Vancouver Coastal Health. Do you guys want to just introduce yourselves? I feel bad introducing such experienced people.
Hello, everyone. I'm Krisztina Vasarhelyi. My role is Senior Learning Health Systems Lead at VCH, and I'm also a member of the Embedded Research Program leadership team.
And hi, everyone. I'm Jessica Stockdale. I'm an assistant professor in mathematics at Fraser University, and I'm the SFU co-lead of the Embedded Research Program that Saad's going to start telling you about.
Okay, so I don't think it's a surprise to anyone in this room that our rates of visible homelessness, sheltered, unsheltered, are getting worse in Vancouver and Metro Vancouver. I think, this is tragic for many reasons. One of which, and what I spend a lot of time thinking about, is the fact that you get sicker the longer that you stay on the street. And so we know that from numerous studies, from what folks who are experiencing homelessness tell us, that chronic homelessness is a major health risk for acquiring infectious diseases, for acquiring a variety of conditions such as acquired brain injuries and so forth, and also deepening addictions. It is also known that housing first models, so actually Vancouver was one of the sites of some of the seminal studies on housing first, that pair-stable housing with wraparound supports can actually alleviate not only the fact of homelessness, but also some of the medical conditions that come with it. So it can actually help this, what we call hard-to-house population. I also spend a lot of time thinking about things like this because we unfortunately see it, which is these kinds of stories where there are increasingly older folks either being evicted from their housing or aging out of place in their living situation and ending up in our shelter system. This is something that we're seeing on a weekly basis, and I think is, for many reasons, a completely preventable tragedy and something that we shouldn't be tolerating as a society. And sorry, we had prepared this on different on Google Slides, so the formatting might have gone off, but as mentioned, the scale of homelessness, of visible homelessness in Vancouver has been increasing year after year, up 30% since 2023 when the last count was done. But we know that this is a national issue. As much as I think Vancouver gets attention, as much as East Hastings gets a lot of attention, at any given night in 2024, 60,000 Canadians were experiencing homelessness. And 1.6 million Canadians, this is the government's own stats based off a 2024 report, have a lifetime experience of homelessness. And as I mentioned that, Vancouver was one of the sites of the Housing First studies, which were known as Chez-Soi at Home. They ran from 2008 to 2013. We're just over a decade after the final report was published in 2014, 2015. And this was extensive. There was over 100 papers published, 2,000 participants. A nuanced take on what they found was, for sure, that we saw permanent supported housing led to faster housing, improved housing stability, so people would spend less time on the street. It would also lead to less system costs, if we're going to make that argument about ED visits and acute admissions. And it held true for a variety of models. It was cost neutral in probably the most conservative formulation of housing first. Once again, being nuanced about it, we didn't necessarily see some of the significant improvements in substance use outcomes or mental health outcomes that we had anticipated at the start of the trials. All that is to say is that I think future directions really do need to look at the models of supported housing that we have. I mean, we use the phrase permanent supported housing. I can tell you that looking at our system of housing in Vancouver, we have 1,967 beds alone that sit in my portfolio for MHSU supported housing. And if you look at the City of Vancouver, BC Housing's definition of supported housing, there's apparently 13,612 beds somewhere in Vancouver. I'm still trying to figure out where they are. And if we look at social housing, once again, as an umbrella term, that's about 50,517 beds. And this is a continuum. So once again, I think that point about taxonomy is really important. We have places where, it's maybe one support worker and you have a bed. And we have places that are really starting to look like long-term care in our system that are still called, and arguably, that are low barrier long-term care. We also know from our own internal research and evaluation that these beds actually do lead to those declines in ER visits and acute care admissions that we had seen over 10 years ago with at-home chez soi. So there's a reason to continue to invest in these models. It's just, I think, we can't keep seeing this. We have to really try to understand and unpack where we're failing as a system and unable to provide for some of the most vulnerable people in our system. And so I think Krisztina will come in and talk about embedded research, but when we had been approached 2 years ago about the opportunity for operations research and embedded research, I really jumped at the opportunity because I think to me, it was not a nice to have, it was a need to have. We have to be rigorous in our evaluation. We have to look at value for money and look at that entire spectrum of housing that we actually have direct oversight over as a health authority.
So thank you, Saad. And in the next few minutes, I'm going to describe to you this so-called embedded research program that we created. And as Saad laid out, it's really was intended to be a way to tackle complex challenges through rigorous methods. And Jessica will talk more about what operations research really is, but I'm going to talk a little bit about what embedded research is and why did we decide to choose this approach for complex health system and healthcare problems. So embedded research is foundational to learning health systems, and a key feature is really that it challenges the traditional partnerships where researchers are the ones responsible for driving the questions and supplying the methods, and health system partners provide access to data and receive the findings and are left with the task of implementation. So the theme of relationship is really important in this conference all day, and we are going to continue with that trend because that is from my perspective, is really the biggest message and the biggest learning from the embedded research program as well, that building on leveraging meaningful long-term relationships, fostering and nurturing them, and thinking long-term is really key to everything. And so that's how the embedded research program pilot started as well. There's a group of us who have known each other and have been collaborating for many years across VCH, Vancouver Coastal Health, and Simon Fraser University. And we came together in, I think it was probably sometime in 2023 with the initial idea that perhaps we could envision an embedded research program pilot. And so this is exactly what we did. We set out to design, implement, and develop an evaluation framework and evaluate this embedded research program. And so the main goal was to intentionally reconfigure that traditional research health system partnership. And so in our pilot, what that looked like is that the VCH partners were really called upon to provide practice-based questions and bring system knowledge to this endeavor. And meanwhile, the SFU partners were asked to contribute their methodological and analytical expertise. And we also set out various values and guiding principles. We actually worked for about a year to develop this proposal that we then eventually got approved both by VCH and SFU leadership. And among the key values and guiding principles, shared accountability and equal partnership were really key and central. And we set out to realize these through joint governance and co-design from the inception of projects all the way to the interpretation of the results, and all of this was baked into everything that we planned. And so, in summary, what this really boils down to is that embedded research shifts collaboration from a knowledge transfer model to a knowledge co-production model. And so what did that look like in practice? Our context was an 18-month operations research pilot, which was made possible by generous funding from the BC Support Unit, and we're really grateful for that. It not have been possible without this, and also co-funding by our VCH and SFU partners, both through cash and in-kind contributions. And we defined 3 key goals for this pilot. One was to build robust evidence to practice capacity, which is really the basis of the LHS model, and also to train researchers with the skills to be able to work inside health systems. So as this presentation evolves and you will know more about what operations research is, Jessica will talk about this. I think the message will come through that not all of it, it's very collaborative, but there is an element of very mathematical and highly analytical knowledge. And so the students and researchers who are trained in that do not usually have the opportunity to train in other skills that are really important for working within the health system. So this is the reason why we made this as one of the central goals. And finally, we already were ambitious and hopeful that what we're creating could be valuable to others who are trying to accomplish similar goals in across BC and certainly at VCH. So we wanted to create an embedded research framework that could potentially be scalable. And so our model is based on or draws upon various embedded research models. We did a literature search and looked at various embedded research models internationally, but also heavily draws on the CIHR Health System Impact Fellowship model with one key difference. So our goal from the beginning was we wanted to embed not individual researchers, but we wanted to create integrated cross-sector teams and include people with lived experience and community members over time, and embed these teams within the health system. And again, relationships. So this pilot program is based at Vancouver's community health program at Vancouver Coastal Health, but also, again, really builds on existing strong relationships with other programs at VCH, including the Regional Public Health Program and the Indigenous Health Research Unit at the VCH Research Institute. And so we set out to build these 3 teams and with a unified structure. So each team had a VCH, or with the Indigenous Health Project, we also had a community, Squamish Nation, lead and team members. And other teams had a VCH lead and other team members, and each team also had an SFU lead, which is an SFU faculty member, so Jessica and the other faculty member, Sandy, who's not here today, and PhD student trainees, and other students as well. And then these 3 teams are guided by a leadership team, which consists of 10 members, both from VCH and SFU. And this team provides ongoing support, meeting monthly, and guidance to the teams. And also a foundational point that was important is we created conditions that would support these teams. So we intentionally ensured that data access pathways were available, administrative support was available, and we, from the very beginning, we did a baseline evaluation, and this is, we're continually evaluating this pilot. So this begins to talk about some of the things that we have started to learn from this experience. We just entered the 18 months of this 18-month pilot, so we're just very close to the end, and we're already thinking about and planning for the next phase. And so one important thing that became available or obvious to us is that to be able to do this work, enabling structures are very, very important. And so some of these are very basic things. So for example, we had to provide VCH network accounts. We had to make sure that calendar and document sharing with the embedded researchers was possible, that they had workspace within VCH where they could work, that they had access to the critical data that they needed. And of course, as I mentioned, monthly meeting with this of the leadership team meeting that was in close contact with the research teams, ensured continuity, removal of roadblocks, advice, and so on. At the same time, an intentional fostering of culture and meaningful relationships and connections was also important. So some of it is just really active participation in these relationships, and it means learning to negotiate different vocabularies, timelines, rigor, priorities. But we also made this as part of our program by building in convenings. We have had 3 so far, and we are planning our final one in May, where we invited our research teams, but also others from both VCH and SFU. And our midterm evaluation is still ongoing, but I'm just sharing a snapshot just to show the positive response that we're getting so far. So this is a snapshot from a survey that was sent to the leadership team meeting. And as you can see, from the baseline to the midterm evaluation, things like goals completely clear, program collaboratively developed, personal contributions valued, they have all increased. And additional surveys, focus groups, document analysis are still forthcoming. And so projects to relationships, this is really our learning that the focus needs to be on meaningful long-term relationship for the work to actually have real strong long-term impact. So what did we learn so far? We discovered that this is mostly anecdotal at this point until we have the final evaluation, but we are able to generate questions and design solutions jointly in this cross-sector group with very, very different experiences. We have considered implementation questions from the very beginning and reaching out to other people within VCH to support that. And we're learning that this continuous and shared learning is possible, and it's already informing decisions even before the final results are in. So this embedded research program model, in our case, is focused on operations research, which Jessica will describe now. But in general, it can apply, we believe, it can apply to many different types of methodologies. It is about creating the conditions for people to come together and support them in collaborating on topics and questions and issues that they choose to work on together. So with that, I'll hand over to Jessica.
Thanks, Krisztina. So yeah, I will finish up our time today by telling you in a little bit more detail what we mean when we say we're taking an operational research focus and digging in a little bit deeper as to the actual projects that we've been working on during the Embedded Research Program pilot. So when I say operations research, in general, I mean research that is interested in improving systems, operations, and decisions. So really getting into the kind of practical aspects of how we deliver healthcare. It can be known by various different names: operations research, OR, management science, management mathematics. But in general, something that is unified across these names is that we're generally combining various quantitative science methods, whether that be mathematical modeling, statistics, data science, machine learning, and AI, with also qualitative research to understand the intricacies of the system that we're working in. So although OR was originally established actually at the end of World War II, mostly focused on military and logistics type questions, it's really grown to be applied to many other complex systems, of which I'm sure I don't need to convince anyone in this room that the health system is incredibly complex and can benefit from these kinds of approaches. As I mentioned, kind of complementing those quantitative approaches, one key part of operations research is really integrating the perspectives and the qualitative experience of people working in the health system, living in the health system, and dealing with it in their day-to-day lives. So that is kind of behind all of that structure that Krisztina discussed before. As to what an operations research project might look like, obviously they're all going to be slightly different, but I hope that this cycle kind of captures the key aspects of a lot of the work that we do. So in general, sorry, the teacher in me really wants to go point at this board, but I've got to stay here. Generally, we've got some real-world system, again, complicated. That could be, as Saad was mentioning, mental health substance use housing network. It could be an individual primary care clinic. It could be a whole network of hospitals or emergency departments. But we've got some large real-world system in which we have a decision problem. So what if I do X? How could I improve Y? To tackle that, we want to combine some qualitative analysis of that system with analysis of data from it, so electronic medical records, administrative data, historical access data, things like that. And we use those two sources of information to construct some kind of mathematical model of that system. So this can be called a digital twin or a virtual representation of that system, essentially so that we can test decisions without having to roll them out in the real world. So what if I decided to build a new clinic here? What if I decided to allocate my staffing hours slightly differently? Here, I can test those things in the simulation without needing to do them in practice to try and come up with some kind of optimal, however we might define that, answer to our decision problem that we started with, that hopefully we can then implement in the real world, and the cycle begins again. I know that we have a learning communities focus on the workshop today, so if any of you are familiar with learning cycles, you might notice that this is really similar to a learning cycle where data informs knowledge, informs practice in a circular way. Some more specific examples of the kinds of questions we might answer. I won't go through all of these for time, but we can use operations research OR to do things like better allocate scarce resources within the health system. So how do I use my finite budget in the best way to achieve the outcomes that I want to do? And in particular, we can use it to balance competing goals. I'll talk about one example of that in a second. We can think about using it to optimize how we're allocating staff as well. So how can we provide provider schedules that are both efficient and fair for the providers and for patients? We can use it to think about optimal locations, whether that be physical locations or service design kind of questions, to provide the best care with particular focus on equity perhaps. So where are we currently underserving folks, and how could we plan future services to respond to that? And it can also have applications clinically as well, so comparing the practical outcomes of different treatment pathways that we might be choosing between. So really everything operations focused. So to return to the problem that Saad discussed at the very beginning, we've been, one of the core projects from the ERP pilot has been looking at client flow in mental health, substance use, MHSU, supported housing. So we worked here to create a virtual model of VCH's MHSU housing network. For time, this is just a very simplified schematic of what that model looks like. I won't go through it, but just to give you an idea. But the key question here was, how can we build a model that captures the key elements of this very complicated system? So it has to capture the key elements, but without adding too much complexity, so that this can be used kind of in real time or in day-to-day operations. It had to be informed by both quantitative data from how people had been accessing the system in the past, and also qualitative expertise. So this model was built in collaboration with the housing clinicians working in the network. We also shadowed at various of the housing sites just to understand and interpret that data in practice. And the eventual aim is to produce a flexible and reusable resource that can be used not just as a one-off research project, but in ongoing use to answer decisions as they come up. Oh yeah, sorry, that's housing first, as Saad mentioned earlier. Just wanted to do a very high-level thing on there, but yeah. And I don't have much time, but to just summarize a couple of the other projects that we've been working on, just to give you that sense of scope. Other projects have involved using machine learning to identify people experiencing homelessness by combining and contrasting community and acute access data so that we can better understand that population whom are very hard to reach. We've been working on determining optimal panel sizes for specialized primary care settings. So for us, that's been working with VCH's community health centers and also the Squamish Nation's Kalnoomet Primary Care Clinic. So how can we decide the number of patients that a provider can reliably serve in a way that ensures access to care, but also quality of care and also the well-being of the provider themselves. So that's a bit of that balance. And then lastly, assessing the health and economic impacts of community-based wound care strategies. So again, a bit of a practical way in which we're comparing different impacts. So I'll finish up by saying that, as Krisztina mentioned, we are coming to the end of our 18-month pilot phase and thinking about really a phase 2 for this work. And we've been so glad to have the support of the BC support unit, and particularly Larry and John in the first phase, thinking about how we scale into the future. So there's been practical aspects of that for us. How do we secure funding for the next phase, but also we're particularly thinking about how we can scale up to better engage patients. So we're aiming to build a learning community, transition that structure that Krisztina presented into a more fulsome learning community, and as well as evaluating and thinking about how we implement the research that we've already done. So I just want to say a big thank you to all of the ERP's research and leadership teams, in particular our 2 students who worked on some of the projects I mentioned today, Mina Moini and Jeremy Chu, as well as really everyone who's been involved in this so far. And yeah, I'll leave our contact here in case anyone would like to be in touch with us. Thanks.
Oh, no, it's fine. It's fine. It's great. Thank you, you 3 as well, to our second group. So does anybody have any questions for... Yes, please. Do you want me here? I can give you...
With respect to co-creating and a new model and deciding on research questions, is there an avenue for patients and public perspective on research questions somehow fit into this?
So in this pilot, we gave the selection of questions big thought, and because it's a pilot, it was in the beginning, our focus was on our partners. So it was focused mainly on our health system partners, with the exception of the Indigenous Health Project, where we have already a very close relationship from the beginning with Squamish Nation. In the future, this is our top priority, and we are waiting for the outcome of funding to build a large learning community for an urban health embedded research program or perhaps embedded learning program. And so that's, I think that the learning community is where really this is a very effective way of operationalizing and democratizing that discussion. So that's our goal.
Any more questions from anybody? Oh.
Other questions?
Thank you so much for that. You spoke a little bit about funding as a next step and a little bit of a question mark, but I'm wondering to date how the embedded research program has been funded.
Somebody else?
Yeah, so as Krisztina alluded to, there was funding from BC Support Unit that we've had. Sorry, I'm just, and then that was really a startup kind of fund. VCH chipped in some money, SFU chipped in some money. So now I think we are also looking at our foundation, and there are some positive signals. That's a bit mysterious to say that, but that's all I'll say. And obviously pending CIHR funding as well. CIHR has the long-standing Health Systems Impact Postdoctoral Fellowship, but they also just launched an embedded early career research fellowship that's for 4 years. So we're looking at that as a way to sustain this.
Hi, Chad Dickey from Victoria. Question around, it sounds to me a lot like team-based care approach, patient medical home approach. How is your intersection and your relationship with social workers? Because the population that you're targeting and working with are very, very integrated and have social workers are a big part of their care trajectory.
Yeah, no, that exactly. So they're like integral to what we do in MHSU supported housing, and I'm very deeply involved in that work.
Anyone else? No? Okay. Thank you very much, you three, and as well to everybody for joining us today. And I won't keep you from lunch, which is going to be served shortly. So thanks, everyone.
Great.